Hello, my name is Vlatka Reskovic Luksic. I'm a cardiologist from University Hospital Center Zagreb. And in this presentation, I would like to say something about the diagnosis of the cardiac source of embolism and emphasize the role of echocardiography in these settings. We know that cardiac embolism is very important as a cause of ischemic strokes. Up to 15 to 30% of those patients have a cardiac embolizations. However, the diagnosis is often very difficult because even if we found a potential cardiac source of embolism, we still have to prove that this is the mechanism for stroke. So this is the really important job for the heart-brain team of cardiologists and neurologists. However, defining cause is of course important because it has therapeutic implications. For example, initiation of the oral anticoagulation or referring patients for a percutaneous intervention. Although echocardiography is most widely used and most important, other imaging modalities in some cases are also very important, such as CT or cardiac MR. Our cardiac societies have released guidelines and appropriate use criteria for echocardiography for different settings, and also for this clinical setting. So the transthoracic echo should be used when we have symptoms or conditions that are potentially related to suspected cardiac etiology, or when we have a suspicion for cardiac mass, infective endocarditis, or other cardiovascular source of embolus. However, if echocardiography is not going to change our clinical management, that there is no sense for using it, especially when we are talking about TEOE, which is semi-invasive procedure. We also have recommendations concerning imaging for the detection of embolic sources. And in those recommendations, the sources of stroke are divided into major and minor. The major are thrombus, both in the left atrium and in the left ventricle, then cardiac tumors, vegetations that can be infective or non-infective, and atheromatosis plaques. Minor sources of stroke risk are spontaneous echo contrast, calcifications on the valves, especially mitral annulus calcification, and then of course atrial septum aneurysm and the patent foramen ovale. So I would like to go through some most important and most common causes of stroke. And in the first place here is left atrial thrombus. So this is the primary source of cerebral embolism in patients with atrial fibrillation, but also in patients who are currently in sinus rhythm after, for example, cardioversion, where the atrium are still stunned and they have not fully recovered their function. So this is the period where the thrombus can be formated. We know that we use Chatzwas score to stratify thromboembolic risk and to try to prevent it by using anticoagulant therapy. However, today we have realized from our clinical practice that there are some other additional risk factors that we can see and analyze on echo. And there are currently some ongoing studies who are trying to define the clinical relevance of those, such as the reduced left ventricle ejection fraction, the dimensions, and the function of the left atrium. So echocardiography can give us many information about left atrium and left atrial appendage. On transthoracic echocardiography, we can measure function by strain, and we can measure area and the volumes of the left atrium. Sometimes when the atrium is very dilated, like in this case, the appendage will be seen. However, this is not enough to visualize thrombus in the left atrial appendage. In our institutions, we always perform TOE prior cardioversion, and this is something that we don't want to see. This is dense spontaneous echo contrast in the left atrium and left atrium appendage, showed on the multiplane view with the formation of the thrombus at the bottom of the appendage. 3D imaging is sometimes also very helpful to distinguish sometimes thrombus from the pectinating muscles of the appendage. However, in some cases, we should use also a cardiac CT to visualize appendage, to do some measurement and to analyze the morphology of the appendage, because we know that there are different morphologies and some of them are more prone to thrombus formation. MRI could potentially be used. However, this is not routine, at least in our clinical practice. However, especially transesophageal echocardiography has many possibilities: 2D visualization, 3D visualization, color and spectral Doppler, and then some newer technologies like tissue Doppler and strain. And there is also something that we should not forget, and that is that if we have inadequate visualization or artifacts, we should use contrast. So if we use all of the possibilities of the echocardiography, we are reaching the sensitivity and specificity for the thrombus detection up to 100%. And we can see that it is even better than for cardiac CT or the CMR. Here is one example. This is the patient which was scheduled for the cardioversion. We see really dense spontaneous echo contrast. And by seeing this, we cannot say for sure if there are some thrombi in this appendage. However, since the restoration of the sinus rhythm was very important for this patient, we decided to perform a contrast study, which you can see here. You can see how the contrast is reaching the left atrial appendage. It takes some time, about 1 to 2 minutes. And after this period, we saw that the contrast agent has fully fulfilled the whole appendage and there are no signs of thrombus, so the cardioversion was safely performed. There are certain groups of patients that are having both high thromboembolic but also bleeding risk with serious bleeding events in their past history. So these are the patients that are referred for the left atrial appendage occluder, which is shown here. You can see here that there is a lobe of the occluder stuck in the appendage, and on the top of it there is a plate which completely covers the appendage and prevents the leakage. And this is how it looks like on the control transthoracic echo. So for the visualizations and the screening patients with suspected left atrium and left atrial appendage thrombus, TTE is used to assess left atrial and left ventricle size and function, and TOE is crucial for assessment anatomy and thrombus before cardioversion or ablation of arrhythmias or some percutaneous procedures such as appendage closure. Very important group of patients are patients with rheumatic valve disease, meaning firstly mitral stenosis. So those are the patients that are at extreme risk for thrombus formation in the left atrium, where there is a really slow blood flow due to mitral stenosis. And we know from the past and previous guidelines that this has always been very important risk factor regardless of the CHA2DS2-VASc score. So regardless of the CHA2DS2-VASc, those patients have always been fully anticoagulated when in atrial fibrillations. However, up to 20% of them are presented with systemic embolism, even if they're in sinus rhythm. And this is the reason why the pivotal study for the NOACs have excluded the patients with a rheumatic mitral stenosis from the studies. And that, so we still have to use warfarin in those patients because the NOACs have not proven their efficacy. Left ventricular thrombi are relatively often found in the patients with cardiomyopathies, especially in dilated and non-convection cardiomyopathy, and as well as the patients with the myocardial infarction and ischemic cardiomyopathy. So acute myocardial infarction is really represents a really prothrombotic state due to blood stasis and necrotic myocardium. And up to 40% of the patients with a large anterior infarction are in a critical period for the thrombus formation up to 3 months after the myocardial infarction. On echo, we can see a different localization and different morphologies of the thrombus. And the thrombus that are mobile, like this one, and pedunculated, have a higher risk for embolization than those who are sessile, like this one. So for the patients with suspected elevated thrombus, TT is recommended for evaluation of the patients with no underlying predisposition for the thrombus formation. Intracardiac tumors are rare, but we still see them in the clinical practice, mostly atrial myxomas, who are the most prevalent among benign tumors. And cardiac sarcomas are most the frequent type of the malignant cardiac tumor. So they can clinically present with embolization, with obstruction of the valves, or with a tumor localization is very important as a risk factor for the embolization, mobility of the tumor, like this myxoma here, and of course the dimension of the tumors are all predictors of embolization. Of course, in some cases, like in this one, by only using the echo, we are not going to be sure if this is some kind of a thrombus or a tumor, so additional imaging modalities should be used. Infective endocarditis represents a risk of a group of the patients who are at really high risk for the systemic embolization. So cerebral emboli are found up to 30% of the patients with infective endocarditis, and we should bear in mind that they are not always symptomatic. Many of them are actually asymptomatic, and that is why in our routine practice, when we are having an on-board patient with endocarditis, we routinely do a CT scan. Size of the vegetation and mobility of the vegetation are actually the most potent independent predictors of embolic events. To raise a clinical suspicion, we should rely on the Duke's criteria. And we can see here in this example of a lady with the endocarditis of the mitral valve. While waiting for the patient to be clinically stabilized to perform TOE, this vegetation is not seen anymore on the mitral valve. So the silent embolization has occurred in the meantime. And the risk for the embolization is the highest prior to starting of the antibiotic therapy. So that is why the establishing the early diagnosis is very important, but also in the first 2 weeks after the initiation of the antibiotics. There are some calculators that, like this French calculator, that actually correlate really well with the clinically observed events. So when referring patients for the suspected endocarditis or the echocardiography, we should actually rely on the Duke's criteria. Prosthetic cardiac valves represent a really major risk for the embolization. So if we have a patient presenting with an embolic event, we should immediately search and analyze the valves. Main complications are thrombosis of the valve and infective endocarditis. You can see here thrombosis of the valve with the really slow flow in the left atrium. And on this 3D reconstruction, you can see a mechanical valve with 2 leaflets, and this leaflet is completely stacked. The clinical situations at risk are early postoperative period in which we have interruption or anticoagulation and also pregnancy. So in these patients, echo and also TOE should be done in the first 48 hours. Because if there is a suspicion on the valve thrombosis, then anticoagulation or even thrombolysis should be performed. PFOs and atrial septal aneurysm we know are really common in the general population and increasing up to 50% in patients with cryptogenic stroke. They often come together. And what we can see, like in this patient with the atrial septal aneurysm, a really small left to right shunt. However, when the patient is performing Valsalva maneuver, so when the pressure in the right atrium rise, we see turning shunt from right to left, representing the risk for the paradoxal embolization. The first step that we should do in those patients is the contrast transcranial Doppler, and if that is positive, then we perform the TOE study in order to analyze in more details the anatomy of the septum and to see if this patient is good candidate for the PFO occluder. Of course, we should always approach individually to those patients and take into account all other clinical contexts, such as, for example, hereditary thrombophilia. So heart-brain multidisciplinary team has to work together to decide an optimal strategy. In conclusion, I would say that echocardiography is the most important imaging tool that we use. However, sometimes it's not going to be enough. We should also use other clinical imaging modalities. Appropriate use of echo means that the findings are going to have some therapeutical implications or impact our decision making. Inappropriate exams, which will not lead to any change in management of the patient, should be avoided. And at the end, those patients are very complex and multidisciplinary approach and individual patient approach is required. Thank you for your attention.